But maybe I start introducing myself. Alexander Mundinger, I'm a radiologist and was an internal specialist before. I'm the director of several departments in Osnabrück, which is a northern town in Germany. And we also run a breast center. And I had the pleasure to be one of these past presidents of IBUS, many years ago. And our topic is tomosynthesis. And tomosynthesis is something that is particularly interesting for radiologists. So maybe you can give me a short overview. Who is radiologist? Okay, thank you. The second question, who has a tomosynthesis at home? Okay, so the majority will probably not be too much interested in details, but nevertheless I included it. So just we start with a little glance on my breast center in Osnabrück, and then I give you information about the technical issues. We talk about the screening and diagnostic setting and the disadvantages, advantages, and some back-home messages. And you will hear another talk, I realized, about DBT, so I split a little bit the contents and start here with the basics, and also why should we be interested in a personalized breast cancer screening, particularly important in Greece, where most of the screening is personalized. Because every woman has an individual variation susceptibility to breast cancer. And this individualized risk stratification helps you for better risk communication, but you also need refined screening strategies to end up in an improved early detection of breast cancers. And this is the primary, the first publication on digital tomosynthesis, and it was about phantoms and mastectomy specimens, but the message was very clear. It is superior to the conventional images, and this is the main key message to you. And if you look at the timeline, how things develop from conventional analog mammography to digital, it was nearly 50 years, but it took less than 10 years that we ended from the beginning of tomosynthesis to high-definition tomosynthesis as we use it today. But why do we need tomosynthesis and ultrasound? Let me add this at an ultrasound course, because mammography has a low sensitivity. Particular, there is a masking effect in women with dense breasts, and there is a reduced specificity due to superimposing structures that cause so-called pseudotumors. And this was the first tomosynthesis we had in our breast center, and it was not our own tomosynthesis. Now we have a new Siemens systems, are very happy with it, but you clearly see on these synthetic images there is a lesion, and this is a clear, not clear, but probable cancer, and here are some lymph nodes on one lymph node. And if you look at the second plane, no question, here is an irregular mass with architectural surrounding distortions. And this is the tomosynthesis with various thick slices, and now it comes out more clearly. And you see the architectural distortion much better. And this is the second plane, and you can see and delineate it very clearly. Once again, the DBT thin slices and the lymph nodes, and this is ultrasound. How big this tumor is in ultrasound. It was a T2 tumor, and to be honest, it was not to hide by mammography, by analog mammography. Here we see the lymph nodes, and here we see the puncture before neoadjuvant chemotherapy. And this is a little clip in these lymph nodes, and also in the primary impressed lesion. And here we see the response after neoadjuvant chemotherapy. So a good story and a big cancer. Today we have implemented in Germany nearly 60% of breast centers and radiological departments and private practices with DBT, and it's the same rate for USA. The base is the digital platform, but I will not only emphasize that it's also good for calcifications, and here you can clearly see how an expanded TDLU is covered by calx. You will get the definition, and digital tomosynthesis is a form of scanning which gives a pseudo three-dimensional image. It's not a real three-dimensional image, but it looks much like a CT. And tomosynthesis takes multiple images of the breast from all different angles. It's not 360 degree, but I will show you just some technical issues, and I will start with a little video. It's a quite old video, and I start just somewhere where this nice lady, a technician, starts with mammography in the CC plane, and now she is preparing the system. And if you look at this tube, it just covers an arc. It's approximately 25 degrees. And if you look now here at these images, you will see these images probably. And she goes on with the second plane, and we start here again, and this is the second plane. So this is a full coverage of the breast by tomosynthesis. And after this, usually the technician scans the images, whether everything is covered, the quality is good. And here you see the typical aspect of a tomosynthesis. And after that, it finally, here you see how she moves through these slides. And afterwards, a radiologist does the same and receives these images for final diagnosis. Fine so far. There are a lot of system differences, and I just will very briefly cover it. It starts with imaging geometry, and it ends with the reconstruction algorithms. And this image is very good to explain that in some of the systems, here the detector is just direct angular to the direction of the X-ray coming from this tube. In others, the detector is not angulated, it's stable, but you see the angles covered differ from approximately 25 up to 50 degrees. And there is a special technique, it's a so-named slot scan, where the center of rotation is not at the level of the receiver detector, it's below. So what means step and shoot or continuous tube motions? It's very easy. In some of the systems like GE, for example, the tube moves, stops, then the radiation pulse comes while the tube is stationary, and then it moves further. A step, stops, next radiation pulse. In the other technique, there's a continuous tube motion, as you know it from helical CT. This means geometrically that there is a little blurring in the direction of the movement. But we have modern mathematical algorithms to overcome this and to reconstruct in a way that this blurring is very limited and looks sharp, like at helical CT. And this was a very nice survey that shows you all the details you should not be interested in, but let me focus on something that's very important to understand the impact of projections and of angular ranges. And you see there's a broad range. The higher the scan angle is, and the more projections, this means the more slices you finally generate, the higher the spatial resolution will be, but the more time it will take. So this is a very good setting for an assessment. On the other hand, low scan angle and less projections means a lower spatial resolution but less time. And this is a setting which is very suitable for screening. And this is the newest update, 2019 to 2020. What do the big vendors offer? This is a GE system, this is a Fuji system, and I just focused on angles, continuous step and shoot technique, and the number of projections, and these three are quite similar. The latest two systems are Hologic, and Hologic is currently the fastest one, and Siemens takes much more time, but if you look at the number of projections, it has the highest angle and the highest projections. So this is a system very well designed for screening, and this is a system that has a focus more on assessment than screening. What are synthetic images? We don't use not only these very thin tomographic images, we also use thicker slices. And if you make a thick slice, a reconstructed slice of the whole breast based on the very thin images, this is just a synthetic 2D mammography. It looks a little bit different because the algorithms are different, and again it depends on the angle, how an image looks like. If you have here a tomosynthesis, not a synthetic image, with a small angle, with 15 projections, it's that appearance. And if you have a better definition, and this is now a synthetic image, and this is a thin slice, then you have more details. I'm sure every vendor will find an example where the own case is the better one, so don't overestimate it. It should just show you the basics behind. And this is how the modern 2D images can be just scanned on a monitor. It just moves, and this movement helps to better delineate the calcifications. The synthetic images are much better for a faster reading of tomosynthesis, and it gives you just a comprehensive visualization. It's just very similar to your normal analog or digital mammography. Radiation dose, a very important issue, and if you look at the diagnostic reference level in US, it's 3.5 milligray granular dose for one view mammography. If, on the other hand, we check what we know from literature, in Germany the average dose per tomosynthesis is 2.2. In other studies, current studies, it was even lower for DBT. And if we look at the one of the very recent studies, it's just DBT 1.8. So we are low with our dose, comparable to the digital mammography. Let's have a closer look on screening environment and screening studies. And first, I would like to answer the question: does DBT detect more cancers than the digital full-field mammography? FFDM is correct, and I don't go into the details of this OTST study, STORM, or the Malmö breast study, but you see that there is an increase of the incremental detection rate, the detection rate that comes in addition to the digital mammography. It's better. That's the very clear consensus from all these studies on DBT, and the increased cancer detection rate is 1.2 to 2.7 per thousand in these studies. Then we have an example, and it's not difficult to see this is a cancer with an architectural distortion, but here we have a very nice extension in the second plane and the lymph node. Next question: does tomosynthesis also detect more DCIS? There are several studies addressing this question, and we see that in this analysis of STORM and OTST, also not only the invasive cancers and the total cancer rate, but also the precursors had a higher detection rate. So the answer is yes, tomosynthesis also detects more DCIS. Next question: does tomosynthesis change the recall rates? And also, here we see, yes, in these studies, in this meta-analysis, it is increased. This recall rate is better. No, help me, just help me. The false positives here are higher for digital mammography, and this study looking at the recalls, favors digital mammography together with DBT. So this is a clear statement for DBT. But if you look not only on the prospective trials, but all the trials, there's sometimes a decrease of the recall rate and sometimes an increase of the recall rate. How can we explain this? It depends on where your primary recall rate was located. Was it high or was it low? And in those studies with a higher than average recall rate for Europe, the DBT decreased the final recall rate after digital mammography. For example, in the STORM trial. And in a previous lower recall rate, for example, in the Oslo trial, it increased the rate from 3.7 to 3.8 after both techniques had been applied. So the message is clear. There is a level where all these studies ends, and it depends on your primary recall rate where you will finally develop to. This is a clear cancer first view. In the lateral hemisphere, this is a corresponding DBT. But you see there's a second finding. And this is definitely also a second cancer, very difficult, nearly not to see in the classical digital mammography. So, more about the diagnostic setting. And the diagnostic setting is the only setting we can use and will be reimbursed in Germany. It can be used definitely as an alternative to conventional diagnostic views and can just substitute spot magnification. And this is also important in cases of calcifications, because you will see these calcifications. You have sometimes to go a little bit slowly through the single slices, but then you will clearly see as good as on spot mag these calcifications. Next question. If you compare it with MRI, there's one study that's interesting. It's from Bosnia, from Draga Organovic, and Dragana found that here DBT was superior to MRI. And if I go into the details of the study, I see first, here are clearly 2 lesions that have been malignant, but the MRI was not really positive, and you didn't see it in full-field digital mammography. And MRI had 2 false negative findings. But it's important to understand that these are lesions with a low proliferation and a strong desmoplastic reaction that results in an architectural distortion. So these can be sometimes not seen by MRI if the wrong compression direction is applied. So there's another interesting study comparing DBT ultrasound and MRI with mammography, but in cases that were suspicious in MRI. And we had in this recent study additional 27 lesions that were detected on DBT and or ultrasound. But if you look at the ultrasound, 24 were detected only on ultrasound. This means the majority of these suspicious lesions have been detected only by ultrasound. So ultrasound has a major role and is better than DBT in these suspicious MRI lesions. And there is a very important interim report of the ASTOUND study, a prospective comparative trial that compares ultrasound and DBT in mammography negative participants. And the important message is, of these 24 additional breast cancers, 23 were ultrasound detected and only 13 were DBT detected. In other words, there were similar results for the other performance parameters. Ultrasound has still a very important role. And this is just an image to show you that you sometimes get different things depending on your performing a digital mammography. Here you can see the calcification is quite nice. This is a contrast-enhanced mammography, and you see an artifact around this hyper-enhancing lesion after the application of intravenous contrast. And here in the tomo you see the architectural distortion very well. What about the tomosynthesis guided biopsy? It's quite easy because you know precisely in which depth the lesion is, and you work very similar like in the like with the stereotactic system, and you get similar results. And there are some studies about that. The advantage of the DBT guided biopsy is that there is a shorter procedure time compared to the stereotactic procedure, and the results are equivalent. So this is a very interesting new approach. And if we look at the performance parameters, this is a summary, and the general message is it's better than digital mammography, particularly with respect to the detection rate. So high variability depending on the time the studies have been performed and the systems they applied. This is one of our cases from our own system, a developing focal asymmetry. And if you have a close-up, there seem to be some irradiating structures, so it looked quite unsympathetic. And this is a synthetic image, and it's gone. It's not really to see on the synthetic images, but you have to consider it's also a different compression. It's a new image. So no correlated pathologic finding. I will come later to this case, but first let us focus on the advantages, which are once again a better detection and characterization of architectural distortions, of asymmetries, a better margin characterization of masses, and particularly the better visualization of speculations. Then we can rule out summation artifacts, which reduces the false positives and which reduces the recall rates. We have a better determination of the 3D localization, and the assessment setting shows us similar results or better results than spot magnification. So in screening we have similar or better results. So finally, this is a good argument for DBT, and this is the ultrasound of this new developing lesion. And if you see this fundamental image, you might be a little bit concerned. There's a shadowing, but in this Siemens elastography, it's not really hard, it's not really hypervascularized, and these are images without and with compression, and so most of this looks not so difficult and suspicious afterwards, but finally we cannot exclude cancer. So here we have DBT, and DBT synthesizers show no really suspicious finding. MRI was negative, so the total Biarritz was reassessed as Biarritz 2 and no biopsy was required. What about the disadvantages? We have false negative cases, particularly in extremely dense breast without fat, and then you don't have a contrast to show the architectural distortion or the changes. We have sometimes motion artifacts and pseudo-calcifications, particularly due to reconstruction problems. And we have additional costs for equipment and storage capacities. It's time consuming. The reimbursement is unclear in several nations, and we need a little bit higher dose when comparing it with digital mammography. These are several calcifications, and in some cases intravenous, oh no, here we have the DBT, and sometimes you can in addition find a cancer. This is really a difficult breast. You look at the calcification, you don't believe there's anything strange, but look again, DBT shows you there's a clear architectural distortion in this area, and this is a little cancer. Okay, let's summarize the indications. They are very similar like MRI and ultrasound, inconclusive findings in mammography, staging preoperatively or after neoadjuvant chemotherapy, symptomatic patients, increased risk including the dense breast, and unclear is whether DPT is as good as ultrasound and MRI for small masses. Here we have a summary from our friend Wendy Berg about the additional detected cancers, and it's 3 to 4 with handheld ultrasound, 2 for ultrasound, 2 also for tomosynthesis, and MRI and molecular imaging are usually better, but these are sometimes selected collectives, and contrast enhanced mammography also had this very good performance. But to be clear, administering contrast medium sometimes is not judged as a really screening examination. If you ask Tabar, for example, he really insists on that statement. So these are not population-based screening tools. The future will be probably really CT, a total photon counting, and this is one of these newer systems. And if you will talk to Jeff about the total photon counting of all the energy levels that photons can deliver, then you will know this is the future, and so it looks like. So, take-home messages. DPT has approached screening, particularly in women with dense breasts. Definitely it has. DPT is both a problem solver and a screening tool, and I'm sure the future of screening will be DPT. But it will be added for a long time by ultrasound. We are ultrasound specialists and we have to work on our skills. But we are multimodality, so you all need to understand DPT, and I thank you for your attention.